Thank you for joining us today. I want to welcome everyone to this installment of the STS 2022 webinar series. This series features presentations and panel discussions on a variety of topics relevant and important to cardiothoracic surgeons. The topic today is current management of stage 3A non-small cell lung cancer, a changing paradigm, sponsored by AstraZeneca. Please note this webinar is being recorded and will be available on the STS website and YouTube channel. We invite you to become a member of STS. You'll enjoy a variety of discounts, benefits, and opportunities to help you grow professionally. Learn more at sts.org/membership. At this time, I'm pleased to welcome our moderators, Dr. Nathaniel Evans and Dr. Jessica Donington. I will now turn it over to you.
Hello, I'm Jessica Donington. I'm a general thoracic surgeon and the chief of thoracic surgery at the University of Chicago. And I'm excited to be joined by my co-moderator for this discussion.
Hi, I'm Nate Evans. I'm a thoracic surgeon here at Jefferson in Philadelphia, and I'm also excited to be here. And I look forward to a lively discussion from our panel about, I think, a very complicated topic about how we manage 3A disease. So I think, luckily, this is a disease that we need multidisciplinary evaluation and care for. And so fortunately, we have a panel of medical and radiation oncologists and surgeons. So I'll ask my co-panelists to introduce themselves, maybe starting with Dr. Carbone.
Hi, I'm David Carbone. I'm a thoracic medical oncologist at Ohio State University and director of the Thoracic Oncology Center there.
I'm Robert Merritt. I'm the director of thoracic surgery at the Ohio State Wexner Medical Center, and I have the pleasure of working with Dr. Carbone and our multi-D lung cancer team.
Hi, my name is Maria Werner-Wasik. I'm the main radiation oncologist treating lung cancer at Jefferson in Philadelphia, along with Nate Evans. And I really have big hopes in finding out more what to do, because radiation oncologists have a lot to learn in this new, exciting for patients and all of us situations.
Excellent. Thank you all very much. So I think we'll jump in. We have a series of questions we're going to go through and ask the panel to sort of weigh in on, and then as hopefully we'll get some questions from the audience. Please put the questions in the Q&A box if you have questions, and we'll do our best to get to those questions as well. So just as a matter of background, before we get to some of the sort of latest changes in how we manage 3A disease, I thought we'd go through it for each of us, for each institution on the webinar, talk about how we managed 3A disease before things like Pacific and Checkmate and all the latest studies that have sort of changed how we manage it. So maybe I'll start with you, Rob. How did you guys manage 3A disease, 3 or 4 years ago?
Sure. So I think the most important point is it is a multidisciplinary discussion. We do discuss all of our 3A patients in our tumor board with input from surgery, radiation oncology, and medical oncology. And I think, it's a heterogeneous group. I think in the past we've done neoadjuvant strategies with either pre-op chemotherapy followed by surgery, and in some instances post-operative radiation. And then some of our patients have been treated with pre-op chemoradiation followed by surgery. So I think it's kind of a, different types of strategies depending on the presentation. Some patients present with a single N2 lymph node. Some have multi-station N2 disease. So there's kind of a different strategy depending on the individual patient.
Maria, how about at Jefferson?
So prior to Pacific, most of patients with stage 3A disease would be treated with concurrent chemoradiotherapy as standard of care. There was always a subgroup of those patients who would be considered for resection following chemoradiation. We are the preoperative chemoradiation institution, not the preoperative chemo alone. And I have an honor to work with surgeons who are comfortable operating after preoperative dose of 60 gray rather than historic 45 gray which allows no patient to be lost, so to say, should they not be able to undergo surgery and having the radiation stopped at 45 gray. Which patient we were choosing? There was no absolute standard. First of all, the patient had to be willing to undergo surgery, and not all of them were. Second, in general, young, good performance status, no weight loss, not overwhelming bulky disease, no bulky N2 nodes. Definition of bulky N2 nodes is murky in the clinical trial. Some of them never had the definition, others had the definition of 3 cm or less. I think definitely less than 3 cm, maybe less than 2 cm. And also preference given to one nodal level of disease of N2. I don't believe we ever operated on N3, stage 3B. I think Nate would agree.
Yeah, I would agree with that. Jessica, what about you guys?
So I love listening to Maria because I think we're so like-minded. But I definitely kind of grew up and started my career in a induction chemoradiation regime. And that's what I was very comfortable with. And I agree, if you're going to radiate, I really believe strongly in going to 60 gray. I don't really think there's strong evidence saying that's dangerous. But I would say in maybe the 5 years prior to, you know, the Checkmate and Empower data, we had really started to move away from induction radiation. It wasn't that we felt it was unsafe, we just didn't know. We didn't know if the benefit was there. You know, do you need two forms of local control? And while, you know, we've always recognized that past CRs would be much higher with radiation, I just don't know that it ever really panned out into overall survival. So we had gone to just induction chemo, and then adding radiation maybe as needed afterwards. And then after lung art, we kind of stopped that too. So I did see, you know, as we're coming into the new trials, a little bit of a separation between the use of chemotherapy, between the use of surgery and radiation in my practice. But I agree with Maria, like, you know, you start down an induction regime and all of these trials have showed us 10 to 15% of people drop off. And then you're kind of always playing catch up a little bit if they're not then a surgical candidate, which is upsetting.
Dr. Carbone, anything to add before we jump ahead?
Well, just that I've been in practice over 30 years and seen a lot of changes. And I would say the majority of places where I've practiced, even a single N2 positive station ruled out surgery. And we did very little pre-op therapy except for Panco's tumors. And those patients would just get chemoradiation. And then the argument was that there was no study showing that one was better than another. And surgery is the modality with the highest cure rate, but that chemoradiation achieved good cures. But today the landscape is different and the discussion is completely different. As Bob said, it's a multimodality decision and with immunotherapy in the mix.
So let's move on to, you know, how do we determine whether someone's resectable or not? I think, Bob, you started, you were telling us, you know, what you think. Who at Ohio State makes that decision? Is it you? Is it the tumor board? Who's really in charge of determining who's resectable and who's not?
Yeah, I think, you know, the surgeons have, I think, the greatest, you know, input in determining who's resectable, who isn't, in the context of a multiple disciplinary discussion. I think there are certain patients, such as, you know, patients with, you know, multi-station, bulky N2 disease, you know, patients with N3 nodal disease, and even in some cases, pneumonectomy may not be an option in patients with poor, you know, pulmonary function. So I think it's important to have the surgeon at the table to really assess, you know, who's resectable, who isn't, because I think there's a lot of nuance and art to deciding, you know, who's a surgical candidate and who isn't.
I agree. Nate, is it different at Jefferson?
No, I think that's exactly right. I mean, I think we certainly just like you guys do at Ohio State, and I'm sure you do in Chicago, we discuss all of our 3A patients with a multidisciplinary group, but clearly the surgeons, I think, drive the discussion about whether or not someone's resectable. And that discussion is not just about the tumor itself. It's about the tumor, it's about the patient, it's about their disease, and what operation we would need to do in order to remove it. So I think I think obviously we're more aggressive with young, healthier people than we are with older people who have more comorbidities. But we try to at least surgeons may not physically see every patient with 3A disease, but we certainly at least discuss their case and review their films, and I think the surgeons guide the discussion about what's resectable and what's not.
Great.
So maybe we could start talking a little bit about Pacific. So the Pacific data and the idea of giving people, definitive chemoradiation followed by Nivolumab, obviously, I think changed the landscape for 3A disease. And I wondered, at you guys' institution, do you think that the Pacific data and the obviously the great outcomes from Pacific changed who you consider resectable and who not, and who did you consider offering surgery to? Maybe I'll start with Dr. Carbone.
Well, maybe I just want to preface this with saying there's a difference between being technically resectable and whether you should do a resection. And our surgeons technically can resect a lot of things that they should not resect. In terms of Pacific, I think the pendulum swung toward doing chemoradiation because the outcomes were so good. I mean, Pacific was one of those landmark trials that just completely changed our practice with a durable improvement in 5-year survival of 10%. And it's now become standard of care. And people that get chemoradiation are doing better. But then came along Checkmate 816. And I think the landscape is swinging back toward the preference to neoadjuvant chemoimmuno, followed by surgery. And we have Checkmate 01 or Keynote 91 and Empower 010 in the adjuvant setting. And so now we're in a difficult setting where you've got neoadjuvant and adjuvant, and we don't know what to do in that setting, but I think we'll get there. If we're talking about chemoradiation, like I said, Pacific changed the landscape and it's now our standard of care.
Maria, what do you think?
I cannot quote numbers, but it is my sense, Nate, from our weekly multidisciplinary meetings that we discuss fewer patients for a resection because the outcomes from Pacific, which I pun intended called an ocean change in management of lung cancer, really changed the landscape. So I don't know the percentage, but I think we operate on fewer people. Nate, what do you think?
I think that's probably true. I mean, I think that especially before the Checkmate and Empower and all the other studies came out, I think that, those people who were kind of on the fence, where we would say, well, maybe they're surgical candidates, we could hopefully get away with just a lobectomy and they might need a pneumonectomy. I think those patients, we were much more likely to consider a Pacific regimen than to kind of put them through definitive chemoradiation and hope that they would get on to surgery. I don't know, Jessica, do you guys do anything differently there?
If I can add something, one more thing, something which is not discussed often enough, I think, is what is the percentage of patients in lung cancer who are unable to get immunotherapy because they have active, autoimmune disease, they have lupus, they have rheumatoid arthritis on 3 different agents and so forth. And we are running in this issue of being not able to enroll patients into for stage 1 lung SBRT plus minus immunotherapy because they're excluded based on eligibility criteria. They have something. So I think once we figure out what is the percentage of those patients, there may be a group which may be more likely to be considered for resection or neoadjuvant approaches.
Do you have a comment, David?
Yeah, I think, and that bears on what's in the chat as well. So it's not just people who are ineligible for, not the chat, the Q&A. It's not just people who are ineligible for autoimmune reasons, but also the PD-L1 and driver gene status definitely bears on decision-making. And I personally would not use immunotherapy in someone with any driver abnormality, with the exception of KRAS and possibly BRAF. But the common ones, EGFR, ALK, ROS, RET, I would not use immunotherapy. It's my perception that maybe 10% or less of patients really are ineligible for autoimmune reasons. There are data that if you have relatively well-controlled arthritis or whatever, those patients still do fine with immunotherapy. The people with bilateral lung transplants, I'd probably avoid.
So, I guess, David, for our audience, maybe you could just go to address the chat question a little bit. We do see patients who have both EGFR and high PD-L1, and that is still a patient that you would not really choose to use immunotherapy in. Is that correct?
That's correct. And I think it's very misleading in a lot of these molecular reports that say high PD-L1 and EGFR, exon 19 deletion, because the report will say this means that it's person suitable for pembrolizumab or whatever. But the fact is these people do not do well. And even with a high PD-L1, EGFR, ALK, ROS, RET mutant patient, really immunotherapy can be considered, but only 5th, 6th line down the road for metastatic disease. And we're focusing here on locally advanced disease. And in terms of Pacific, especially, the people with EGFR and ALK did not benefit, but also the people with PD-L1 0 did not seem to benefit to adjuvant durvalumab. And there is a toxicity to maintenance durvalumab after chemoradiation. So in my practice, I actually suggest not giving durvalumab to patients with PD-L1 0 tumors, though I know that many of my colleagues do anyway, since it is approved in that setting. So in my practice, durvalumab, I hold or I suggest against it to patients that have PD-L1 0 as well.
Thanks. So the next trial that kind of came out after the Pacific trial was really the Empower 010 trial. They gave us our first look at any survival impact. And how did that change, how you looked at your 3A patients, Bob? Did that suddenly make more people seem operable? Did it change your induction strategy? How were they viewed in your institution after Empower 010?
Yeah, no, I think that trial, specifically, kind of reevaluated, our adjuvant strategies. In the past, we would offer, 4 cycles of a cisplatin doublet for patients with, nodal disease on their path report or, large tumors. And now we have a new agent, immunotherapy. So I think it more impacted our adjuvant strategies, particularly for, patients who had, incidental N2 disease picked up on the final path. So we have introduced that new strategy in our armamentarium for our 3A patients. So I would say that it more impacted our adjuvant strategies.
And Maria, can you comment about Jefferson and whether that changed even how you induce people, or did that stay the same after 010? Would it change an upfront 3A and how you approach them from the get-go?
I'll refer to Nate to start that discussion from the surgeon's point of view.
Yeah, I think I would sort of echo what Rob said. I think for us, Empower 010 was really more important for the adjuvant setting and the patients who are sort of those quote surprise 3A disease. You know, I think that if we knew they had 3A disease going into surgery, we probably would have given them some sort of neoadjuvant approach. You know, in our institution, like I said, it's usually chemoradiation. And I think it was exciting, obviously, to be able to offer those patients some type of immunotherapy, but we didn't necessarily change anything based on the Empower. I think, you know, we are a pretty sort of neoadjuvant heavy institution. I think I personally sort of buy into that idea that it works better in terms of getting all the therapy to the patients. So I think we were more excited, as we'll talk about, I'm sure, in a few minutes, about Checkmate. But yeah, so that was our approach. I think very similar to Rob's.
Yeah, I think we totally are all in agreement that for stage 2 or unsuspected 3A, it was great, but it didn't really change how we approach a 3A patient de novo, because we just rarely would take those people to surgery as a first step. And I don't think the data was strong enough to change that approach.
Yeah, agreed. And I guess so the same question sort of about, we talk about Checkmate 16 and when because the next trial that came along would be the neoadjuvant trial, right? You know, the trial of giving neoadjuvant platinum doublet and Nivolumab. And I know certainly in our institution, you know, we actually had a similar phase 2 study here. And I think we kind of had been sort of socialized to that idea already. But I do think it's sort of, as Dr. Carbone was saying, sort of swung the pendulum about how we manage 3A disease. And I'm curious, well, maybe we'll start with you, Rob. How did you, did it change how you guys approach 3A at Ohio State?
I think it probably impacted more kind of the stage 1B and stage 2 patients. Obviously, you know, our 3A patients who, you know, express PD-L1 are also, you know, considered for the neoadjuvant strategy. But the interesting thing about, you know, Checkmate 816 is that it includes the early stage patients, yeah, which, you know, traditionally we haven't really considered neoadjuvant therapy for this population. Whereas 3A, you know, that idea is already socialized. We were used to doing it, but for the earlier stage patients. But I think an important point is now we have to get biomarker testing before we consider neoadjuvant strategies, particularly to check for EGFR mutations, as David mentioned earlier, and also to see what PD-L1 expression is. I think the patients that have high PD-L1 expression clearly benefit the most from the immune checkpoint inhibitor therapy. So that's one of the challenges with this population is we don't want to delay surgery too long or therapy. But biomarker testing sometimes can, you know, be inconvenient and cumbersome. So I think we have to figure out how to make it more streamlined and to talk to our pulmonologists to make sure that they send enough or get enough passes during EBIS or their navigation bronchoscopies to have enough material to do biomarker testing.
I totally echo the issue. I think, you know, stage 4 patients, we all got really good at, you know, sending off a liquid biopsy as soon as possible. I think our oncologists got really good at getting everything set in that kind of 10-day window, and they were ready to go. And in the early stages, we're still terrible at it. Like, we're really bad at it. My pulmonologists are like, oh, no, it just takes us 3 days. And I'm like, oh, no, it takes 4 weeks. And that's not, you know, it just, you know, by the time they see them, they get them on the schedule, they do the biopsy, we send a full gene panel. So that's 10 days on its own. It's just, yeah, we're not streamlined in any way, shape, or form, but it's important.
And I mean, it's a little bit off topic, but that's also like a total paradigm shift, right? Because some of these patients, some of the early stage patients, we weren't even biopsying before. Like we would just operate on them, right?
Right.
And now it's, I
4
think,
centimeter tumor, you would just
Yeah.
take it out.
yeah.
Yeah.
But it also means that you need to engage your pulmonologist in the therapy decisions, which they usually were just involved in staging and diagnosis. But they, as Bob said, if you get them to send the genetics day one when they get the path result and they are trained to get adequate biopsies, you can bypass all this so they can have the molecular by the time the patient is ready for surgery.
Yeah, it's just, it's a workflow we haven't all figured out yet. And to tell you the truth, we all work at universities. We all sit at the same tumor boards. You know, my pulmonologists are, you know, they're in the same building.
Yeah, mine's
I
right there
really-
next office.
Yeah, I guess the one place that I'm even more concerned about what happens in the community. I sit on a community tumor board too now, and it's really messy.
Availability of
Oh, just
biopsy
we
is
send
not
them
as good,
to, oh, I'll call.
right?
Maria, what's your sense about how Checkmate 16 changed our approach to 3A? Do you feel like it's changed yet, or is it changing?
Well, as you mentioned, we were running this phase 2 small trial from Jefferson with Ralph Zinner of neoadjuvant chemoimmuno, and we remember how you as surgeons were blown away by the early results, right? That time it was sort of unheard of.
Yeah.
We didn't quite believe how good it is, confirmed now by larger trials. But I think we haven't quite adopted it all 100% such an approach for stage 3A. And that may change after the results of the NADIM trial are published, which is a phase 2 trial devoted solely to stage 3A patients. Not necessarily 3A, I think there are some more advanced there, but
3A,
stage
3B.
3.
You're right.
3B, yes, stage 3. I stand
The
corrected. So
Europeans are
stage,
very aggressive.
so stage 3 patients and only stage 3, not a contribution from earlier stages, which muddles the waters. So with the PCR rate of 37% in the combined arm versus 7% in the chemo arm alone, you can't quarrel with those results, even though the double digits complete pathologic response rates were historically reported in chemoradiation trials, but not to the level of 36%. Well, with 60 grade, the mediastinal clearance rates were 60%, but never translated into survival benefit, as Jessica said. So I think we are in between.
Yeah.
We are thinking what to do and don't feel fully comfortable, but it will come down to including patients with multiple nodal and 2 disease, which were included in NADIM trial, T4 patients, stage 3B patients, and they seemed all to have benefit as far as I understand from the preliminary presentations of that study.
Yeah, I mean, I think as Rob was mentioning earlier, it seems like more and more what's driving that discussion is what the patient's PD-L1 status is, right? I think if someone's got 3A disease and the PD-L1 status, PD-L of 80%, then it's much easier to make an argument for giving them a neoadjuvant chemo IO approach than if it's 5%.
There's a really good question in the chat too that's asking the same thing. Does, the extent of the PD-L1 expression, allow surgeons to think more aggressively? If you have someone who kind of comes in and has maybe multi-station disease or a T4 tumor that's big, maybe they would, normally need a pneumonectomy. And maybe we wouldn't have done this surgically 3 or 4 years ago. If they have a PD-L1 of 80 or 90%, are you much more willing to give it a try? Have you become more aggressive?
But there's a risk to that. I think the 816 trial, the eligibility was up front, they had to be surgically resectable. And there's a risk to kind of pushing that boundary a little bit and saying, well, I would never operate on this patient, but maybe I'll get a response and then it'll become operable. And that's not really what 816 was designed to show. And And I think many people were enrolled in that study that actually were upfront inoperable, because you look, there was about a 20% of people never went to curative intent surgery. And of the ones that went to surgery, about 20% didn't have R0 resections, which is way higher than other neoadjuvant trials. The LCMC3 trial had 92% R0 resection rate, and after neoadjuvant immunotherapy. So I think there is a little risk in being too aggressive, taking too bulky disease patients to surgery. But it is possible to think about giving a couple of cycles of chemo IO in the future, and then making a decision about chemoradiation versus surgery at that point. But this is not what 816 was about.
Right, but that 60% pass CR rate in the high expressors is very tempting. It is, it's just sitting out there. It's so alluring. 60% is a lot.
It is. And then the other question that's in the Q&A about whether this person had a lot of fibrotic response with a path CR that required a conversion to open thoracotomy. If you look in 816, actually the number of conversions was less in the chemo IO arm than in the chemo arm. And the number of minimally invasive surgeries was higher. So I think there are certain cases where the surgery, the response causes a fibrotic reaction, which makes it more difficult. But I think in overall in 816, that was not the case. And it was actually less often that you needed to convert to an open procedure.
I totally agree. I've done a lot of post-induction surgery, and I don't think this is in any worse world than what we were seeing with chemo alone or with chemoradiation. I mean, they're all hard. Let's face it, they're not easy. These are not stage 1 tumors. These are hard, but it doesn't mean it's not worth doing them.
Yeah, I know. I don't know. I've found that the chemo IO group is more variable in terms of the response, how challenging. Some of them, are pretty straightforward, and some of them are, as bad as the worst chemoradiation cases we ever did. But like you said, I don't think that it's anything new or different than the other neoadjuvant cases. I'm just looking through the questions in the chat here, but before we get to that, I do want to get to one question that we touched on earlier, but I think this is like the one I'm most excited about hearing everyone's thought on today. Is we touched on, what do you do with people who have driver mutations? So Dr. Carbone, someone shows up in you guys' clinic tomorrow with this, with 1 or 2 into stations of a 3A adenocarcinoma with a driver EGFR mutation or ALK mutation. What is your approach to that patient?
Well, I would ask Bob if he thinks it's surgically resectable. I would not give neoadjuvant chemo IO with a driver mutant status. And I would be inclined in such a patient to do definitive chemoradiation without durvalumab. However, right now it is approved to do adjuvant osimertinib in an EGFR mutant case, even though there's never been a proven survival benefit to that approach. It's all disease-free survival, and there's benefit to disease-free survival. But what really impresses me is the early and clear separation of the survival curves in 816 that you don't see with adjuvant osimertinib. So
just to clarify, that in that patient, let's say Dr. Merritt says it is resectable, then would you send them directly to surgery and then give them adjuvant osimertinib, or give them neoadjuvant chemotherapy or something first? I'm sorry to put you on the spot. I'm just very curious about this particular.
I'm not a huge fan of a neoadjuvant chemotherapy. I would probably send them to surgery, do adjuvant chemo, and follow that. Offer them osimertinib, but tell them that it's not been shown to have a survival benefit, and you're paying $150,000 and experiencing the toxicity of osimertinib for 3 years. and you may not need it. So I'm not real enthusiastic about adjuvant osimertinib, but I'm very enthusiastic about neoadjuvant chemo IO, especially in node-positive patients. But you have to do the molecular testing. And there's a question in the Q&A about PD-L1 status. And it is true that high PD-L1 had more benefit, but I would offer it to any patient because chemo IO does seem to benefit even low PD-L1 patients. Keynote 189, the persistent benefit in low PD-L1. So I think that we do need better biomarkers, especially in a surgical setting, because there are people who are cured with surgery alone. Yet we are now giving them highly expensive, potentially toxic therapies for long periods of time, and they may not need it, and they may not benefit from it. So, we do need better ways to select patients who need additional therapy, and to select from those the ones that specifically benefit, and from what immunotherapy combination they would benefit the most.
Yeah. At my tumor board, that is like the post checkmate patient is like, it's like the Wild West. I got oncologists saying, taking that data every way from Tuesday and arguing for what they should get next, whether they're past CR, whether they're, major pathologic response or residual disease, and they don't agree on anything. It's really it's really amazing to watch.
Yeah,
and I don't think it's going to get better with the next wave of trials.
It won't. It'll get worse because Checkmate 816 was 3 cycles of neoadjuvant with no adjuvant. We have 2 positive adjuvant trials, and we have a slew of trials that are both neoadjuvant and adjuvant. And so today, if you have a patient on 816 with neoadjuvant 3 cycles, you don't know whether they would benefit from adjuvant or not. And I get this question from community docs all the time. Great response, 10% residual tumor. Should I give them 010 adjuvant? We don't know. And we're talking in ECOG about designing a phase 3 to ask that question. But there's a lot of pushback saying that that's an undoable trial.
I do think that trial belongs in the cooperative groups, though, because no pharma company is doing it. So
yeah, well,
it's
that's my position is that's
trial.
A perfect trial for cooperative groups to do, and they're chicken if they don't do it.
I completely agree. And because I do think that we're probably overtreating, we're going to be overtreating a bunch of patients.
Jessica, I saw your response when he said he was going to send the 3A patient with EGFR directly to surgery. So I'm curious how you guys would manage that.
So we've had some of this, not a ton, probably seen more on the coast than we've seen, but we definitely see it. And we have given them induction chemo and then resection. And my oncologists have a really hard time pulling away what they call curative chemotherapy in the 3A population. So we would do induction chemo, we would resect, and then move to osimertinib as kind of our strategy. I thought when the ADURA trial came out, I would not see so much induction. I would see a little less chemotherapy in our resectable EGFR mutated patients, but no, they really, in my opinion, hold on to that because they really do see that, similar to what Dr. Carbone said, as the chance for cure that you're just not going to get with a TKI.
Maria, what do you think? I mean, my sense is that those people were giving chemoradiation before surgery. Is that your sense?
For EGFR positive?
For resectable patients who happen to be EGFR positive, yeah.
Yes, or just chemoradiation. On the mock oral boards for my residents, I ask them, patient comes in with stage 3 and EGFR positivity, and they're like dumbfounded. What should they answer? Which drug should they use? And then we arrive at the answer that the standard for stage 3 lung cancer EGFR mutated is definitive chemoradiation for most patients. But for the occasional resectable, yes, chemoradiation before.
I will say that I know across town, at least some of the surgeons, some of the oncologists across town are offering people neoadjuvant targeted therapy followed by resection.
Well, there's definitely a trial.
Yeah, which I think is a very interesting trial. It would be another interesting. It's hard to find enough patients for that trial, but
Yeah, you're not going to find those patients in the Midwest, unfortunately. So we don't have that trial, but I don't know. It'll be interesting.
That trial was tried by Hak Choi many years ago. Induction medications for EGFR or ALK, followed by radiation to a smaller tumor because it had shrunk. So,
Did it work?
well, at that time, the reflex testing for the molecular abnormalities was not done widely. Therefore, there were not enough patients to enroll, and the study closed.
Well, there were 2 Chinese studies that looked at neoadjuvant TKIs, both very small, and neither one showed a survival benefit to neoadjuvant TKIs. In fact, one of them showed that the neoadjuvant chemo was better than the neoadjuvant TKI. I think it's worth testing. The NeoAdora trial is the one you're talking about, the random phase 3. That won't even finish accrual for another couple of years. So we're not going to know that question for a long time.
Right. But I do think we're going to find a lot more EGFR patients now that we're looking for them. So I think this is going to become a more common question for our tumor boards. There is another good question in the chat, and it goes back to our conversation about what we recommend in the resected Checkmate 816 patient. And I guess, David, if someone has not had a major pathologic response and has a fair amount of residual disease, what is your approach after surgery in those patients?
Yeah, that's a really excellent question. If you look at the people with a PATH-CR, they have an excellent event-free survival. In fact, high PD-L1 patients that had a PATH-CR have an almost perfect 3-year survival. It would be very difficult to show the benefit of additional therapy. PD-L1 negative PATH-CRs, they do get PATH-CRs, but they actually do relapse. And so what to do in those patients is a question. If you look at the people that don't get a PATH-CR, there's a little bit of an improved EFS in patients who got chemo IO compared to chemo, but not dramatic. It's the majority of the EFS benefits is in the people that got PATH-CRs. So it's a huge question of what to do with the people who don't get PATH-CRs. And you could argue both ways. One is, well, maybe another year of therapy, they would do better. But the other argument is, you showed that this therapy is not really effective in this patient. Why are you going to give them another year of ineffective therapy? So it's a huge question. And right now, I tend to go by clinical trial evidence. And Checkmate 816 did not use adjuvant. If I use 816 neoadjuvant, I don't give additional adjuvant. And we're never to have the definitive randomized trial to answer that question unless the ECOG trial gets approved. But we'll have cross-trial comparison evidence when the trials with neo and adjuvant chemo IO readout, but that's going to be over the next few years.
So we've talked a fair amount about neoadjuvant approaches. How do you guys approach, or is there any role for sort of restaging people in between when they get their quote, neoadjuvant preoperative therapy or going to surgery? Maybe I'll start with Robert.
Yeah, I think we have to, follow the data from, Checkmate 816. You give your neoadjuvant chemo IO and you operate it if they have resectable disease. I don't think there's any real accurate way to, test for PATH-CR, without, doing surgery. I mean, that's kind of the best determination on how they responded to the neoadjuvant therapy. So I would say if they are resectable and they're good surgical candidates, we should just proceed with surgery, as they did in the study.
Jessica,
I
you guys
agree.
any different?
I agree. Even before Checkmate 816, I was not a restager after induction therapy, be it chemo or chemoradiation. I know they don't do as well if there's residual N2, but they probably do better with surgery than with nothing.
But what is unanswered is whether you should give after 816 if they had N2 disease. Maybe it cleared, maybe it doesn't. Should you give post-op radiation?
That's a really good question. I like that.
What do you think, Maria?
Well, that's exactly the issue I've been thinking about. What would be potentially the role, if any, of radiation with this new algorithm of induction chemoimmuno followed by surgery. We know from the ART trial that irradiating N2 disease did not reach the primary endpoint of prolonging disease-free survival as assumed. Whether those patients with N2 persistence after immunotherapy are different breed than those after induction chemo, or in the ART trial, it has to be understood better. And I agree that we'll need more markers. I think there's preliminary evidence that circulating tumor DNA in the NADIM trial was associated with PCR. So I think that a lot of research has to be done in this area. But how would we design the trial for persistent N2? Patient would have to be randomized again, right? To radiation versus no radiation. Any such randomizations of radiation in one arm and no radiation in the other historically have not been easy to enroll patients, even though it's a scientifically valid question to ask.
Yeah, but hard for patients to accept. Maria, have you seen a lot of patients who start down a Checkmate 816 and then are not surgical candidates? And are you offering those patients radiation at that point?
Nate?
I don't think we've been there yet.
Yeah.
Well, we've done specific trials of neoadjuvant immunotherapy before chemoradiation. The AFT16 trial, for example, that we were one of the leading institutions for, gave several cycles of atezolizumab before a chemoradiation. And the outcomes, it was a single arm phase 2, but the EFS and OS outcomes of that trial are at least as good as Pacific. And there are people that think that that approach actually has advantages, because when you're giving radiation to the draining lymph nodes that are supposed to be responding to tumor antigens, you may not induce as much of an immune response as if you give a few cycles of immunotherapy before chemoradiation. So I don't think it would be wrong. In fact, I know of a trial being designed right now that looks at marginally resectable patients, it gives chemo IO, and if the surgeon decides not to operate, they go ahead and give chemoradiation. And I think that that's actually a reasonable approach, though not supported by trial data right now. Another
potential approach to incorporate radiation early before surgery would be to use just the a 3-fraction immunomodulatory regime of like 8 gray times 3, not with the purpose of eradicating a tumor, but the stimulating of the immune response. But it's a far-fetched, yet an idea to consider potentially.
In the Q&A, they're asking about 816 for Pancoast.
Oh yeah, Elliot apparently has read ahead in the script here.
Yeah, he definitely has the script somewhere, doesn't he?
But
it's a good question.
It is a great question.
Approaching Pancoast now.
Yeah, I know I'm going to have Maria. I know Maria has strong feelings about this, so I'm going to let her start about how to manage Pancoast.
Well, I have strong feelings until now. What will be in the future, I don't know. But Pancreas tumors is a specific disease different from the others. I asked my residents again, what's the difference between Pancreas tumor and other lung cancer? And they don't know what to answer again. I said, Pancreas tumor grows out of the chest. It grows out of the chest into the brachial plexus and chest wall and so forth, possibly vertebral bodies. Therefore, the issue of local control is of paramount importance, because otherwise patients end up with morbid pain and dysfunctional arm and just awful end of life. So I'm in the camp of giving chemoradiation, not to the historic SWOG 45 gray, but pushing the dose to 60 gray, and even being able to give a higher dose to the spinal cord with those tumors invading the vertebral bodies.
I have to say, I have not seen a Pancreas tumor since I moved to Chicago, which is weird. I feel, and is it just me? Like they don't come to us here at the university, or what? Has anyone noted fewer of these, or is this just my my region?
I mean,
Still,
I think
go ahead, Nate.
Go
No,
ahead.
we still see them here in Ohio, and I think we pretty much follow the SWOG clinical trial where you give pre-op chemoradiation, and if they don't have N2 disease on MEAT or EBUS, then we would proceed with resection en bloc, chest wall, sometimes maybe a small portion of the brachial plexus if feasible. But yeah, I mean, we still follow the neoadjuvant chemoradiation approach.
Yeah, I don't. They didn't exclude Pancreas tumors from Checkmate 816, did they? Did they?
Kind of can't remember.
I can't remember either. I don't think we did from our phase 2 study, but I think we all were a little bit nervous about it. And I think certainly our approach, just like to Maria's point, is the main goal is local control, and I think so that's why we've kind of fallen back on chemoradiation for that group.
Well, almost by definition, a Pancreas tumor invades the chest wall and potentially adjacent nervous, tissue. And so I'm not sure you would consider that person resectable up front. So I'm not sure that would be technically eligible for 816 because they were supposed to be de novo resectable patients.
Reasonable.
So I know that Ray-O does have a trial through the cooperative groups. I believe it's a SWOG trial, trying to incorporate immunotherapy into the preoperative treatment for Pancreas tumors. But he's really been challenged in getting patients on this trial, which I thought was like a little surprising because you're right. I don't think it was well addressed in the Checkmate trial. And I mean, we use SWOG 9901 as our thing, right? Does that mean that trial came out in 1999? Bob, were you in high school then?
No, I'm not that young.
But it's not new data, right?
Yeah. You asked the question. I know Jessica asked a question earlier about sort of what to do after Checkmate. I guess the reverse question is, are any of you seeing patients who've been treated on a specific regimen who then have residual or recurrent disease? And is there any role for sort of salvage surgery, or how are you managing those patients, if you see them? Maybe I'll start with Robert.
Yeah, that's a great question. I think, if they do recur, local regionally, I mean, I think surgery would be a consideration for a salvage approach. We may have operated on maybe one or two of those patients, but obviously, the difficulty of the operation would probably be great, especially if they had, bulky mediastinal disease. There will be lots of fibrosis in the hilum. So if it's, lobectomy, we would probably attempt resection. But if it were a pneumonectomy, maybe not. Probably would not offer surgery in that population, but we would certainly, consider a lobectomy in a salvage setting.
If it's a recurrence in the primary tumor only, then SBRT would be an option. But most of those patients recur metastatic, and they fall in the lap of the medical oncologists. And it is a real question of if you've gotten maintenance durvalumab, do those patients respond to the Keynote 189, to the chemo IO metastatic regimen? And probably not as well. And the same thing applies to people who've gotten perioperative immunotherapy when they relapse. We don't really know how to best treat them. And in fact, I've had insurance denials of first-line metastatic immunotherapy because the patient got immunotherapy after chemoradiation. And I think that that may well happen with perioperative immunotherapy as well. Though that's our standard of care in first-line metastatic, and that's what I would do until proven otherwise.
And David, that brings up a question, which I think I know the answer to, but I'm not sure. So someone who's gotten a year or two of durvalumab, is there issues, complications, problems, any clinical reason or just insurance reasons why you can't go from one immunotherapy to another? Durva to Pembro, Pembro to Nivo.
Well, there's no data that switching immunotherapies in a patient benefits. So it would be hard to say if someone was high PD-L1, but then progressed while on Durva, that you should give them single agent pembrolizumab. I don't think that that would really be reasonable. I would give them chemo Pembro with an expectation that they may not do so well. I think insurance will drive the answer to a lot of these questions for sure. But also there's a question pretty often during the maintenance durvalumab after chemoradiation, a patient has a touch of pneumonitis that requires you to stop the immunotherapy, maybe give some steroids, or maybe just discontinue immunotherapy. It's a little touch and go whether you should use immunotherapy in that patient with the risk, I think, a higher risk of recurrent pneumonitis. But those patients are in a lot of trouble if they have metastatic recurrence after Pacific regimen. And so I would usually give it a try anyway.
Great. Well, this has been a really awesome discussion. Thank you guys all for your time. I don't know if there are any other questions in the chat I think we got to all the questions in the chat, right?
I think we got them. They were good chat questions. Thank you to the audience.
Thank you everybody for being here, and thank you to the participants, because I learned a lot, and now I hopefully we'll figure out how to manage those EGFR patients. But thank you all very much, and I really appreciate everyone's discussion.
Great, thank you.
A sincere thanks to our panelists for your participation and insight tonight. We also thank AstraZeneca for their support. Register today for the STS 59th annual meeting and plan to reconnect with your colleagues in cardiothoracic surgery in San Diego. STS members receive a registration discount. Learn more and register at sts.org/annual meeting. Thank you and good night.